building on this. So we have ipilimumab, which appears to produce long-term survival in about 1 in 4 patients with widespread melanoma. We have the PD-1 approaches that seem to be benefiting almost 2/3 of patients with melanoma. What about combining them together? And Dr. Mario Sznol, a professor of medical oncology at Yale School of Medicine, will discuss his very exciting early results with the combination.
Thanks, Steve. Let me just thank the ASCO organizers for selecting this abstract to be presented. And I also want to make mention of my co-collaborators, Dr. Wolchuk at Memorial Sloan Kettering, and then 2 new collaborators, Dr. Atkins at Georgetown and Dr. Kirkwood at Pittsburgh. Dr. Ribas is very hard to follow. First of all, the data is amazing. And second of all, he has this amazing accent. I spoke Spanish first, too, and I don't have that amazing accent. So but I'll try and do as well as he did. In collaboration with Memorial and the other investigators I just mentioned, we conducted the first phase 1 trial of concurrent ipilimumab and nivolumab. Ipilimumab you've heard about before. Nivolumab is another anti-PD-1 agent, very similar to the pembrolizumab that was just presented. And this trial was conducted in patients with metastatic melanoma. These are 2 distinct immune checkpoint inhibitors, so it makes sense to combine them together. And they both, as you've heard, produce very significant clinical activity as monotherapy in advanced melanoma. Now, the data that we're presenting, part of the data that we're presenting was presented last year. So the initial data on cohorts 1 through 3, the first 53 patients were presented at ASCO last year by Dr. Wolchuk, and actually the data was published in the New England Journal. And that presentation showed, that data showed that the objective response rate was 40% with the concurrent administration of ipilimumab and nivolumab. And we felt that there was something different about these responses. We thought that the responses were, at least compared to historical controls, more rapid and deeper, better quality. And we saw that in about 1/3 of the patients. And although the data wasn't in the New England Journal of Medicine publication, Dr. Wolchuk showed initial survival data last year of 80% at 1 year with very limited follow-up. So the objectives of the presentation this year is to report updated safety data, survival, and clinical activity for the initial 53 patients that were reported last year with a combination regimen. That's cohorts 1 through 3 with 1 more year of follow-up. But we also want to just show a little bit of activity data, the response data on a new cohort of 41 patients that were treated using the regimen that was used in the phase 2-3, the subsequent studies, especially the phase 3 trials. And in this you can see here that the induction is the same. They received the same induction schedule for nivolumab and ipilimumab, but in cohorts 1 through 3, we gave nivolumab every 3 weeks for another 4 doses, and then we gave the combination every 12 weeks for another 8 doses. In cohort 8, which is the schedule that's been used in the phase 3 trials, the induction was the same, but then after the induction, we only gave nivolumab 3 milligrams per kilogram every 2 weeks for up to 2 years. This is the survival data, and this is the main point of the presentation. And what you can see here is that the 1-year survival, the survival data for the 4 different cohorts is this line, this line, this line, and this line. And this is the overall survival data for all the first 53 patients. The 1-year overall survival data was 85%, and the 2-year survival data now, with further follow-up, is 79%. And although this is a small trial, that's a very significant 2-year overall survival rate. Significant meaning very, very impressive 2-year overall survival data. There were other aspects of the clinical activity that go along with the survival data. Over the last year, the confirmed complete response rate with further follow-up in those first 53 patients increased from 10% to 17%. I actually believe that's probably an underestimate because it's very hard to call a complete response these days with the sophistication of the CAT scans. And probably the number of patients that had true complete responses is probably higher than that. And that's suggested by when we look at the overall tumor reduction in tumor measurements, we saw greater than 80% tumor reduction in 22 out of the 53 patients, so in almost 42% of the patients that were treated in that initial cohort. And I can tell you that many of those patients had near complete responses. The responses were durable. 18 out of the 22 objective responses at the time of the data lock are still ongoing. The median duration has not been reached. There have been questions as to whether this regimen would be as active in patients who have BRAF mutations, which have other options, targeted therapies, and at least in our experience, this regimen was just as active in patients who had BRAF mutations as those who had wild-type BRAF. And also, with the use of anti-PD-1 alone, nivolumab or pembrolizumab, there seems to be an enrichment of responses in patients who have PD-ligand-1 expression in their tumor prior to treatment. At least with this regimen, there appeared to be no difference in activity in those who had PD-ligand-1 low tumors or PD-ligand-1 positive tumors at baseline. It suggests that we're picking up activity in patients who might not have responded to anti-PD-1 alone. And then, of course, one always, with a small cohort of patients, one wants to know that you can validate this in a subsequent cohort. And in fact, we treated an additional 41 patients, and the response rate in those 41 patients was 43%. Objective response rate was 43%, which is very similar to what we saw in the first 53 patients. So we feel very confident that the activity of this combination regimen is real. So what about safety? So there's no question when you combine ipilimumab, which, as you've heard, has a fairly high incidence of toxicity, with nivolumab, that you're going to see increased toxicity. And in fact, we did. We saw grade 3/4 adverse events in 62% of patients. Now, and that obviously would raise concerns. However, we were impressed that these events were very similar to what we've seen with ipilimumab. They were manageable and reversible with algorithms that were established for ipilimumab. In the vast majority of patients, all of the adverse events were reversible. There was one drug-related death in that last cohort of 41 patients that resulted from the consequences of colitis. Overall, though, in this last 41 patients, we saw new safety signals, and we feel fairly confident that these are adverse effects that can be managed with a little bit of education and training. And certainly it appears as though the activity of the regimen would justify the increased rate of adverse events. So the overall conclusions, the concurrent therapy with nivolumab and ipilimumab produced, and this is a controversial word, but we believe unprecedented 1- and 2-year overall survival rates of 85% and 79%. Of course, these are small cohorts of patients, and this needs to be verified in phase 3 trials, which have been completed. At least in our preliminary experience, it did appear that the overall survival was higher when we used nivolumab doses greater than 0.3 milligrams per kilogram. So the overall survival looked a little bit better in the higher dose cohorts, but of course these are small cohorts and again needs to be confirmed. We saw substantial activity in patients who had PD-ligand-1 low or negative tumors, which suggests that we are doing something different than anti-PD-1 alone. We saw significant activity in patients with BRAF mutations, which means that this is a very good option in addition to targeted therapy for patients who have BRAF mutations. The increased rate of adverse events is real but manageable with algorithms, and I think the adverse events are justified by the increased activity. And the definitive trials, the phase 2 and 3 trials, which will answer the question, the enrollment has already been completed. One compared the combination to nivolumab versus ipilimumab, and the other one compared the combination to ipilimumab alone. Thank you for your attention.
Thank you, Mario. So I almost feel like I'm looking at childhood leukemia survival curves of when we're starting to approach 80% plateaus. So it's really, that's why, as you can tell, that's what is so palpably excitable about melanoma. Now, I will caution that this is, as Mario has rightfully done, this is a small group of patients, approximately 50 patients that they're reporting on. And ultimately, the response rate does not appear to be significantly different, at least than historically what the monotherapy for the PD-1 antibodies are. I think the proof of the pudding will be survival. As you know, this class of drugs in general, immunotherapy, has a more pronounced effect on survival than anything else. And certainly these early results with 80% 2-year survivals is very impressive. If that holds up, that will be one thing, but that it will have to win, I think, on that level. And obviously, as Mario said, there's costs in terms of toxicity, and the sequence, since there's little cross-resistance between the agents, It's not absolutely clear that combining them versus sequencing them will be the best optimal approach for patients in terms of toxicity and survival. So our final talk will be, now we're going to break out of melanoma